Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Bharat J. Parmar. Sir is MBBS, MD, DHA, FIAMS, Professor and Head of Pediatric Department at Zydus Medical College and Hospital, Gujarat. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is From Diagnosis to Cure Pediatric Leukemia Update. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Yes. Good evening to all. First of all, I am very thankful to IGCP Group for giving opportunity to me highlights my view about acute leukemia update in children. The leukemia is the commonest pediatric malignancy, accounting one-third of all the cancers. It may be defined as malignant clonal proliferation of lymphoid and myeloid precursor cell in the bone marrow, as well as infiltration of other organs with this cell. Depending on the predominant cell line and the presentation, these cases are subclassified as acute lymphoblastic leukemia ALL, acute myelogenous or non-lymphoblastic leukemia AML, and chronic myelogenous leukemia CML, and juvenile myelomonocytic leukemia JMML. All the acute lymphocytic leukemia is the commonest leukemia in children, about 77%, followed by acute myeloblastic leukemia 11%, chronic myeloleukemia 2 to 3%, and juvenile myelogenous leukemia, that is 1 to 2%. Remaining cases do not fit classification definition of any type. Acute lymphoblastic leukemia. The childhood acute lymphoblastic leukemia is considered as a prototype for the cancer research and being the first disseminated malignancy cured by chemotherapy and irradiation. Currently, 70 to 80% of these cases are potentially curable. Incidence of acute lymphocytic leukemia is estimated 3 to 10 per lakh population and being 3 to 4 times more common in male and peak age incidence between 3 to 7 years of age. Although the exact etiology is not known, important hypotheses about this leukemia suggest there is a genetic basis due to higher risk in twin and sibling of index case 3 to 4 times, or in many genetic syndrome 10 to 20 times, that is Down syndrome, Bloom syndrome, Fanconi anemia, neurofibromatosis, and congenital immunodeficiency disorders, and agammaglobulinemia and ataxia telangiectasia. Chromosomal abnormality, aneuploidy, and translocations are present in 80% of the leukemic cells, and the environmental basis due to occurrence of many cases in geographical clusters or as a second malignancy after radiotherapy and chemotherapy. Pathology about this acute lymphocytic leukemia. Acute lymphocytic leukemia is characterized by increased number of the lymphoblasts in bone marrow with or without their presence in peripheral blood or infiltration to other organs. A lymphoblast is characterized by typical morphology. There is a high nucleus cytoplasm ratio and dense nuclear chromatin and basophilic non-granular cytoplasm, and cytochemical characteristics, that is presence of coarse granule and the clumps on the pass staining and the absence of peroxidase on Sudan black positive granule and non-specific esterase reaction. Biological markers, the presence of terminal deoxynucleotidyl transferase and activity in B progenitor and T cell lymphoblast, which is absent in a normal lymphocytes. Classification about this leukemia in children. The WHO classification of acute lymphoblastic leukemia, there is a B lymphocytic leukemia, B lymphocytic leukemia 85%, an earlier term pre-B and early pre-B acute lymphocytic leukemia, and the T lymphoblastic leukemia 15%, earlier term T cell acute lymphocytic leukemia, and the Burkitt's leukemia there is a less than 1% arising from mature B cell. Clinical presentation of acute lymphocytic leukemia. Initial symptoms in acute lymphocytic leukemia are generally non-specific and mimic a viral infection. There is a fever, anorexia, lethargy, and nearly two-thirds cases present with 4 weeks of onset of symptoms with the following features. And the signs of primary bone marrow failure, there is a pallor, fever, persistent recurrent infection, there is a leukopenia and mucocutaneous bleeding, there is a thrombocytopenia. And the signs of secondary organ infiltration, there is a mild lymphadenopathy, splenohepatomegaly, bone and the joint pain due to perichondrial bone infiltration and subperiosteal hemorrhage, and the headache and vomiting due to the meningeal involvement. And the signs of mediastinal mass, there is superior vena cava compression, dysphagia, dyspnea, and common in T cell leukemia. The diagnosis of acute lymphocytic leukemia. The diagnosis is usually suggested by the presence of lymphoblast in a peripheral smear, though needs to be confirmed by bone marrow examination, by aspiration or biopsy for a complete morphological, immunological, and cytogenetic study. The hematologically severe anemia is present in 25% and thrombocytopenia in 75%. In childhood, acute lymphocytic leukemia, the leukopenia is more than leukocytosis. Other investigations are necessary to identify the secondary organ infiltration or as pre-treatment workup for monitoring and the drug dose adjustment for chemotherapy. The diagnostic workup in leukemia, the screening, peripheral smear for a blast cell, the diagnostic, bone marrow aspirate and biopsy for severity and extent of the disease. There is a blood profile for hemoglobin, total leukocyte count, platelet count, X-ray chest for mediastinal mass and tuberculosis, and CSF examination for blast cell in CNS involvement, and there is a meningeal leukemia, and skeleton X-ray in case with bone marrow, bone pain, and the pre-treatment workup, that is serum uric acid and the renal function test. Then the liver function test, coagulation profile, serum electrolytes, serum calcium, and the serum phosphorus. The differential diagnosis of acute lymphocytic leukemia. The differential diagnosis of acute lymphocytic leukemia include other causes of there is a bone failure, there is a aplastic anemia, infiltrative disease, there is a secondary involvement of other malignancy, and the atypical lymphocytosis in case of infectious mononucleosis or pertussis, and the splenohepatomegaly or lymphadenopathy, rarely cases with bone and joint pain, may be confused with other cause of arthritis. There is a rheumatoid arthritis. The management of acute lymphocytic leukemia. The management of leukemia include specific treatment of first attack, and second there is a supportive treatment, third monitoring, early diagnosis, and the treatment of relapse. Specific treatment of initial attack depend clinically anticipated risk for release. There is a risk directed therapy. The standard risk patient with average risk of relapse defined as the age between 1 to 10 year, total leukocyte count, it is more than 5 lakh, less than 5 lakhs per millimeter cube, and the B cell immunophenotype, and the rapid response to chemotherapy with less than 0.1% minimal residual disease, that is burden of leukemic cell in bone marrow on a day 29 of induction, and absence of mediastinal mass or CNS involvement, and absence of hyperdiploidy or other chromosomal abnormality, that is translocation. The standard risk treatment revolve around multi-drug chemotherapy, and many protocols are used for this purpose. In general, it may be divided into three phases. First, there is a remission induction phase. There is a 4 to 6 weeks. Second is consolidation and intensification phase with CNS prophylaxis and systemic chemotherapy for 14 to 28 weeks. And then the maintenance phase for 2 to 3 years with intermittent reinforcement therapy. The treatment regimen for standard risk for acute lymphocytic leukemia. The induction phase for 4 to 6 weeks, there is a IV vincristine, there is a 1.5 milligram per meter square weekly, maximum 2 milligram, plus intramuscular asparginase 10,000 units per meter square biweekly, plus orally prednisolone 40 milligram per meter square daily, and intrathecal CNS prophylaxis. There's a weekly during induction, then 8 weekly for the 2 years. There is intrathecal methotrexate 10 to 15 milligram per meter square, plus intrathecal hydrocortisone 10 to 50 milligram per meter square, plus intrathecal ARA-C, there is a cytarabine 20 to 30 milligram per meter square. Maintenance therapy after induction phase for 2 years, and there's orally 6 mercaptopurine 50 milligram per meter square daily, plus orally methotrexate 20 milligram per meter square, and reinforcement therapy every 4 weeks during the maintenance therapy. There is IV vincristine 1.5 milligram per meter square single dose, and plus orally prednisolone 40 milligram per meter square for 7 days. The diagnosis and treatment of relapse case of acute lymphocytic leukemia. The common site of the relapse are bone marrow, CNS, and the test is also termed sanctuary sites for blast cell. The absence of relapse for 2 years is usually considered as cure. The bone marrow relapse is the site of relapse 15 to 20% cases, and identified by periodic bone marrow examination. There is more than 5 blast cell per high power field during or after chemotherapy, and the late bone marrow relapse, it is more than 18 months, is usually treated with the reinduction therapy similar to the first attack but with the different drugs. including CNS prophylaxis followed by longer maintenance therapy. Early relapse, there is a less than 18 month or during the treatment it need more intensive chemotherapy followed by bone marrow transplantation, and the CNS relapse is relatively uncommon, less than 5% after the use of effective CNS prophylaxis in all the cases of acute lymphocytic leukemia indicated by signs of raised intracranial pressure. Symptoms are headache, vomiting, and on examination, papilloedema, and seizures and cranial palsy, and hypothalamic involvement. There is excessive weight gain or behavioral changes. The diagnostic rests on the CSF examination showing elevated pressure, pleocytosis, and the presence of leukemic cells. Even a single blast cell in the CSF suggests CNS relapse. These cases should be treated with weekly intrathecal therapy till lymphoblast disappear from CSF, followed by cranial irradiation and preventive CNS therapy as in initial attack, and simultaneous systemic chemotherapy due to the high risk of bone marrow relapse, and the testicular relapse occur less than 2% and present with painless swelling one or more both testicle confirmed by on testicular biopsy, and these cases are treated with irradiation of gonads and the simultaneous systemic chemotherapy including CNS prophylaxis as in a first attack. Supportive treatment for acute lymphocytic leukemia. The supportive treatment required to manage complication of the disease as well as chemotherapy include maintenance of adequate nutrition and the hydration, correction of fluid electrolyte imbalance, correction of severe anemia by packed cell transfusion, correction of bleeding problem by platelet transfusion, and the prevention, early diagnosis, and the treatment of nosocomial infection, and the treatment of metabolic complication, that is hyperuricemia by allopurinol, and monitoring and the treatment of chemotherapy related adverse effect, and the psychological support to the patient and the family. What is the prognosis in acute lymphocytic leukemia? The overall cure rate in acute lymphocytic leukemia about 80%, though varies with the risk status of the patient and adequacy of the therapy. With the current therapeutic regimen, cure rate is more than 90% of the standard risk case and 50% for T cell leukemia and 20% for B cell leukemia. The bad prognostic indicator include age of the presentation less than 1 year or more than 10 years, high leukocyte count, there is a 5 lakhs per millimeter cube on presentation, and the mediastinal and CNS involvement on the presentation, and the presence of chromosomal abnormality, there is hyperploidy, translocation, and delayed remission or early relapse on the treatment. So these are the prognostic criteria for this acute lymphocytic leukemia. Today's lecture, the message about the today's leukemia update, there is a childhood acute lymphocytic leukemia is one of the most common cancer in the children, characterized by clonal proliferation of immature lymphocytes, there's the lymphoblast in bone marrow, and the prognosis depend upon the age of the child, extent of the disease, type of the clone, and the genetic mutation. And the therapy include chemotherapy, radiation therapy, and chemotherapy with stem cell transplant, and targeted therapy and immunotherapy. The child with acute lymphocytic leukemia may relapse after and during the treatment, and the site of the relapse include bone marrow, testes, and the central nervous system. Thank you. Hello.
Hello, sir. Am I audible?
Yes.
Yes, sir. So, sir, we do have some question if you like to take that up.
Yes. Yes.
Yeah. So, sir, just let me read out the first question to you. Yeah. So, the first question is, how do we differentiate between leukemia and other hematological disorder in children?
So, in case of acute lymphocytic leukemia, the chief complaint is pallor. And this pallor, it is severe, it is sudden onset, severe, and the progressive one. So, first there is a anemia associated with leukocytosis and thrombocytopenia with bony tenderness, with superficial cervical lymphadenopathy, with splenohepatomegaly. So these are the presentation symptoms and the clinical signs of acute lymphocytic leukemia. So most important is leukocytosis and thrombocytopenia, and there is a gum bleeding.
Thank you, sir. The next question is, how do treatment outcomes compare between all and AML in children?
So I already told this outcome of this acute lymphocytic leukemia with this supportive treatment and the initial induction treatment and the maintenance therapy, there is a overall outcome is about 80%.
Thank you, sir. There is one last question. What are the most promising research development in pediatric leukemia?
So in pediatric promising after bone marrow transplantation, the curative treatment of this acute lymphoblastic leukemia is a stem cell transplantation.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, sir, any take-home message from your end?
So whenever any child presented with severe sudden onset progressive pallor with bleeding tendency, with splenohepatomegaly, with superficial lymphadenopathy and bony tenderness, until proved otherwise, it is acute lymphocytic leukemia.
Thank you so much, sir, for joining us today. And with your permission, I would like to conclude today's session. Thank you.
Okay, thank you. Good day.